I'm excited to introduce our speaker today, Dr. Alison Stuebe. Dr. Stuebe completed her obstetrics and gynecology residency at Brigham and Women's Hospital and Mass General Hospital in Boston. She completed fellowship training in MFM at Brigham and Women's, and she earned a master's in epidemiology from the Harvard School of Public Health. She has published more than 200 peer-reviewed articles. She is currently a professor of maternal fetal medicine at the University of North Carolina School of Medicine and distinguished professor of infant and young child feeding at the Gilling School of Global Public Health. She's been awarded grant funding from the NIH, the Agency for Healthcare Research and Quality, the Patient-Centered Outcomes Research Institute, and the American Heart Association. Her current research focuses on advancing justice, belonging, and humanity in maternal health. She's a member of the steering committee for Moms Rising North Carolina, and she is actively engaged in professional organizations. She's a past president of the Academy of Breastfeeding Medicine and a former board member for the Society of Maternal Fetal Medicine. At the American College of Obstetricians and Gynecologists, she's a member of both the Breastfeeding Expert Work Group and the Maternal Mental Health Expert Work Group, and she chaired the task force on reinventing postpartum care. Thank you for joining us today, Dr. Stuebe.
Thank you so much for having me. Thanks for being up early your time. So we're going to talk today about breastfeeding, chest feeding, and reproductive justice. I have a couple of disclosures. One is a financial disclosure about a technology that I'm not going to talk about today. As Dr. Crow mentioned, I've received research funding from a number of places, but I also want to state my positionality. So I'm a white, cisgendered, heterosexual professor at an academic medical center. And particularly pertinent to this presentation, I have 3 children and I've breastfed for a total of 10.5 years. And I think it's really important to recognize that all of us have an infant feeding story. These are my 3 boys. This was about 6 years ago. They're all much taller now, and the smallest one is now the tallest, much to his brother's chagrin. But Noah, my first kiddo, was born the night before the match when I was a 4th-year resident. I'm sorry, a 4th-year medical student. So if there are medical students in the audience who do not want to be stressed during match day, I highly recommend a 24-hour primiparous labor to take your mind off the match. Sam was born the first day of my research block when I was a 3rd-year resident, and Max was born 3 weeks after I started working at UNC. And I think that these stories are so important because Sam, for example, did not sleep well at all. In fact, he had 3 separate visits with the actual Dr. Ferber. I'm sorry, 2 visits with Dr. Ferber. It feels like 3. He is now 20 years old. He still does not sleep through the night. And so when a patient asks me about their baby's sleep, my brain goes to Sam and I start thinking about things that are about my personal experience, not about my medical expertise. And it's very easy for me to give really strongly worded advice that is based entirely on my personal experience. And I've had to just recognize that and take a breath and say, talking to you as a mom, I had 1 kid who didn't sleep, so this really resonates with me. And what we know from the medical literature is. And I think that naming that, I hope, gives a little bit of distance, but I also recognize that my position as a physician and a professor, and I don't wear a white coat, but wearing a Patagonia jacket might give people the impression that I know more than I actually do about a particular topic. So many of us have been parents, even more of us have been aunts, uncles, best friends of parents, even more of us have been siblings, and all of us have been babies. So we all bring our own infant feeding experience to the space of breastfeeding and chest feeding. And I want to name that because those of us who've had bad experiences may either be really fired up to help people or really frustrated and think we should tell people just not to do this because it was awful for us, it might be awful for them. And we can't negate those experiences we have, but I think it's really important to own them and name them so that we can provide patients with the kind of independent counseling and shared decision-making that they deserve. So without further ado, today we're going to talk about the relationship between lactation and health outcomes for birthing parents and their children. We're going to discuss infant feeding within the context of reproductive justice, and I'm going to share some tips about how maternity care providers can enable women and birthing people to achieve their infant feeding goals. So let's start with the relationship between lactation and health outcomes. This was a study that Melissa Bardick led in 2017 that was a simulation study to look at the health impact of suboptimal breastfeeding and chest feeding on birthing parents and children. And what we found in this simulation study was that if the population met optimal breastfeeding recommendations, which is 90% exclusively breastfeeding for the first 6 months and then continuing for a year, it would prevent 2,600 birthing parent deaths and 721 child deaths annually. One of the striking things about this is that the health impact was actually greater for the birthing parent than for the child. And I think we often think about breastfeeding and chest feeding as something that's important for the baby and that the birthing parent sort of has to bite on a stick and do it. But in fact, it's even more impactful for the parent's health. So this is the breakdown of the deaths and diseases averted. So we know that lactation reduces the risk of breast cancer. Longer lactation is linked with lower risks of type 2 diabetes, hypertension, heart attacks. And so when we enable our patients to breastfeed or chest feed, we potentially reduce their long-term risk of multiple health conditions that are really important for their lifetime well-being. We also know that there's a profound impact on the health of children. So children who are breastfed have lower risks of leukemia, ear infections, Crohn's disease and ulcerative colitis, GI infections, lower respiratory tract infections, childhood obesity, and necrotizing enterocolitis. And so when we enable people to breastfeed successfully, we have a profound impact on the health of their children. Just recently, a paper was published in Diabetes Care that looked at the lifetime duration of breastfeeding and cardiovascular risk in women with a history of type 2 diabetes or gestational diabetes. And they found that there is a substantial reduction in risk of coronary heart disease and cardiovascular disease with longer durations of breastfeeding in those individuals with diabetes. So when we think about the patient with GDM who we're seeing multiple times during prenatal care and advising them about how to control their sugars, advising them about the importance of follow-up, we also want to be supporting them to initiate and sustain breastfeeding if that's their desire, because that could profoundly impact their long-term health. However, even though we know that breastfeeding and chest feeding are highly impactful, most parents discontinue feeding earlier than desired. So this was an analysis that we conducted in 2014, looking at risk factors for early undesired weaning attributable to lactation dysfunction. So we defined that as stopping breastfeeding earlier than desired for problems with latch, pain, or low milk supply, at least 2 out of 3. I actually wanted to call this lactastrophe. The journal editor was not having it. We went back and forth several times. The word lactastrophe is in the text, but it is not the title. However, when I see patients who are having a really difficult infant feeding experience and I tell them this sounds like lactastrophe, they invariably laugh and they know exactly what I mean. So if you've seen patients with lactastrophe, you know that sometimes this doesn't go well. And we, as the providers of healthcare for the birthing parent, need to be able to support families to work through these issues or to come to terms with what's going on and be able to have a positive infant feeding relationship. Now, differences in breastfeeding and chest feeding reflect socioeconomic drivers. And so these are data from the California Department of Public Health looking at breastfeeding intention and duration by race, ethnicity in the San Francisco Bay Area. And what we see is that individuals racialized as white are more likely to be exclusively breastfeeding at 3 months than those racialized as Asian, Black, or Hispanic. We also see a relationship between neighborhood poverty and lower rates of exclusive breastfeeding. Now, there's nothing about being a person with dark skin or a person of Asian or Hispanic ancestry that makes breastfeeding more difficult. These are reflections of structural factors and structural racism that affect folks' capacity to breastfeed as desired. Similarly, poverty doesn't make you have less milk, but poverty certainly reduces the access to support, paid family leave, and those kinds of resources that enable breastfeeding to occur. There are also intersectional issues. So this is the one study I could find that looked specifically at sexual minority identities and infant feeding outcomes. And the authors found that individuals who identified as lesbian or bisexual were more likely to never breastfeed or breastfeed for less than 1 week. So we see here that for individuals with sexual minority identities, it may be more difficult for them to initiate and sustain breastfeeding or chest feeding. So when we think about structural factors that are constraining people's reproductive options, and a reproductive option is to lactate and feed one's child human milk, it raises the question about how infant feeding fits within the context of reproductive justice. So The reality is that throughout the US history, the fertility and childbearing of poor women and women of color were not valued equally to those of affluent women. And if you're not familiar with stratified reproduction, this is a fabulous paper by Lisa Harris and Tida Wolf that walks through the various ways that throughout our history, we have constrained or disdained, honestly, fertility and childbearing among particular groups that have been made marginalized. And in addition to forced sterilization and coercive contraception, barriers to allowing individuals to infant feed are an example of how reproduction has been stratified in the United States. And as Dorothy Roberts writes in her seminal book, Killing the Black Body, the thing about reproduction is that more than anything else, it tells you how a society values people. I had not read Killing the Black Body until about 10 years ago, and I regret my practice as an obstetrician before I had this context about the ways that our well-intentioned behavior can have really terrible effects. I think that there was a period in my residency and even fellowship and evening attendinghood where someone would say, I talked you into an explanton. I would give them a high five, like talking someone into an explanton was a triumph for democracy or for anything. We should never be talking our patients into things. We should be supporting our patients to make informed decisions and providing them with objective information, and then assisting them with determining what aligns with their preferences and values. Now, the antidote to stratified reproduction is reproductive justice. Reproductive justice was conceived by women of African descent for reproductive justice in the early 1990s, in part in frustration at the exclusive focus of a lot of white cisgendered feminist thought about reproductive health as being all about access to abortion. Now, access to abortion is absolutely necessary for reproductive justice, but it is not sufficient. Reproductive justice is defined as the right to bodily autonomy, the right not to have a child, the right to have a child, and the right to parent the children we have in safe and healthy environments. And breastfeeding is an example of number 4, the right to parent children in safe and healthy environments. And the reality is, although in the community of well-to-do white women, breastfeeding is often perceived as something that they are feel guilty about not doing, for many women and birthing people, it's not a choice because they can't breastfeed, because they face structural barriers that simply make it impossible. And if we're going to talk about the health importance of breastfeeding and chest feeding, we need to talk about removing those barriers so that people can act on that right. So this is a wonderful commentary from the ACLU about the challenges of breastfeeding as a Black person. And the author talks about racism, about the sexualization of Black bodies, about the fact that because of structural racism, Black individuals are more likely to be in low-wage jobs that have less support for lactation. And they make the case that battles to safeguard breastfeeding rights must be accompanied by efforts that remove barriers to making that right something everyone can exercise on equal terms. Neither where a person lives, works, and gives birth, nor a person's race or gender should determine whether they have the option to breastfeed. And so that's really what I want to talk to you all about in this portion of the talk. And I think that we often think about reproductive autonomy in terms of whether to become pregnant or whether to be able to end a pregnancy. But sometimes we lose track of, for example, that for many low-income individuals, they don't have access to infertility treatment, so the right to have a child is constrained. And while certainly every individual has a right to decide not to breastfeed, we also want them to have the right to decide to and act on that decision to breastfeed. And right now, that right is constrained. And this mismatch between reproductive rights and the right to breastfeed can be traced back to the Convention for Elimination of Discrimination Against Women, which was written in 1979. And as Judith Galtrey points out, at that point in time, breastfeeding was considered one of those chains that prevented women from full autonomy. And as she writes, it did not always occur to policymakers and legislators that many women did not actually have the right to breastfeed. And I think this echoes the sort of white feminist, cisgendered, well-to-do concept that women had the right to go to work. There were lots of women who had been working throughout human history and would have liked to not have to work and would have liked the right to maternity leave. And so this is another example of how the autonomy and how to parent has not really been centered. So I also want to quote Sabia Wade, who's a brilliant doula who's written a great book called Birthing Liberation, How Reproductive Justice Can Set It Free. And they say the reality is that some Black birthing people, especially those with intersecting oppression, such as being low income, disabled, working beyond full time, etc., are often not given the choice to body feed and are instead pushed into formula feeding because they do not have any support or resources that would allow them to body feed their child successfully. So I really think this is a reproductive justice issue. So what does it mean to have a human right? Well, United Nations defines human rights as entailing both rights and obligations. States assume obligations and duties under international law to respect, to protect, and to fulfill human rights. So respect is the obligation that states must refrain from interfering or curtailing the enjoyment of human rights. Protect requires states to protect individuals and groups against human rights abuses. And fulfill means that we must take positive action to facilitate the enjoyment of these basic human rights. So what would it look like for us to respect, protect, and fulfill the human right to breastfeed? Well, the Office of the High Commissioner on Human Rights wrote about this specifically in 2016, noting that women have the right to accurate, unbiased information needed to make an informed choice about breastfeeding. They also have the right to good quality health services, including comprehensive sexual, reproductive, and maternal health services. They have the right to adequate maternity protection in the workplace and to a friendly environment and appropriate conditions in public spaces for breastfeeding, which are crucial to ensure successful breastfeeding practices. And so we're going to talk about good quality health services and the OB provider's role in the third part of the talk. But for now, I'm going to focus on these other three items: the unbiased information, workplace protection, and public spaces. So we don't have access to accurate and unbiased information. And this is an editorial that accompanied three really impactful papers in The Lancet last February about the predatory tactics of the formula milk industry. And the editorial makes clear, and I want to be clear, that the use of formula is not predatory. The use of formula is something that people can make an informed decision to do. There are individuals who want to breastfeed and are not able to do so, and they need commercial milk formula. However, women and families make decisions about infant feeding based on the information they receive. And a criticism of the commercial milk formula industry's predatory marketing practices should not be interpreted as a criticism of women. The problem is that marketing by the commercial milk formula industry is an interconnected, multifaceted, powerful system that knowingly exploits parents' aspirations. And so in much the way that the Sackler family and the opiate industry tried to convince providers that everyone needed OxyContin and that it wasn't addictive and it was great for them, and created a market for something, and then said you're making people feel guilty if you don't treat their pain, the formula industry has tried to create a market for the idea that every parent needs formula. Not only do infants need formula, but there are now growing up formulas that go through 3 years of age, which cost more than milk or other nutritious foods, and cost more to produce and have more impact on the environment, and make billions of dollars for the formula industry without serving any health end. So in the Lancet series, they have adapted these to not have actual formula company names here, but these accurate and biased information is not there. It is very common to show babies in glasses or babies doing math in the background, suggesting that a particular formula is going to increase IQ, even though there's no evidence to support that claim. Similarly, there are formulas marketed that are supposed to help babies sleep through the night when babies are 2 months old. Babies do not sleep through the night, but moms are really tired and dads are really tired and parents are really tired at 2 months, and they get a free sample in the mail saying, help your baby sleep at night, get some rest, as though this formula is going to solve the problem, and it is not. This is also a $53 billion industry. And every time a baby goes to breast or to chest, the $53 billion commercial milk formula industry loses a sale. So there have been examples of leaders at formula companies saying on earnings calls, the good news is that more parents are going back to work, so we can expect formula sales to go up. There have been examples of them criticizing maternity leave protections because they recognize that their market share is going to go down if people have the ability to be with their infants. So this is a big pharma, big formula industry that is deliberately undermining infant feeding. So the Lancet series outlines some of these structural factors, and it's really impactful and important to read, but I just want to highlight, first of all, 97% of the traded share value is owned by shareholders in high income countries, even though harms disproportionately affect low and middle income countries. It's an underregulated multi-billion-dollar industry, and governments have regularly challenged other government attempts to regulate commercial milk formula marketing. In 2018, the US threatened to not support an important security UN resolution regarding Ecuador, because Ecuador was favoring a resolution that would have made restrictions on formula marketing, and the US dairy industry got really upset about it. This made headlines in the New York Times. So this is a big deal. It's a big business. Their marketing tactics exploit emotions, aspirations, and misleading science at the expense of the health and rights of families. And I think really importantly is that these companies fund and influence health professional research and medical and academic organizations. If you've ever been to the AAP meeting, the lanyards have formula company names on them. I remember going to the meeting in DC 6 or 8 years ago, and the entire that was before everyone had phones to do their email, and there was a bank of computers that were sponsored by a formula company, and there were big smiling signs of babies with bottles in their mouth. So they're actively promoting their product to the detriment of health and well-being. And there are powerful lobby groups that are actively blocking efforts to regulate marketing. Of note, in 1981, the World Health Organization passed a resolution called the Code of Marketing of Breast Milk Substitutes that prohibited direct-to-consumer advertising of formula. Clearly, that is not enforced in the United States and has not been enforced globally. And then just as an example of how these companies manipulate us as providers, this was from a training manual in the 1990s about nurses and formula. So Ross is the parent company, is a formula company, and they taught their salespeople, never underestimate the importance of nurses. If they are sold and serviced properly, they can be strong allies. A nurse who supports Ross is like an extra salesperson. So I know I did not go to med school to be sold and serviced. I don't think any of y'all went to med school to be sold and serviced, but this is the way the formula industry thinks about us as providers and actively attempts to get us to tell our patients, oh, honey, it's okay. You can just give your baby formula. Now, I want to be clear. There are patients who need to give their babies formula. And again, I'm not criticizing parents who choose to formula feed or parents who need to formula feed. I'm criticizing formula companies that convince patients and providers that maybe everybody should just have formula in order to sell their product, which is absolutely not okay. So the second piece that the UN High Commissioner on Human Rights named is maternity protection in the workplace. And this is a UN publication on state obligations regarding the impact of the business sector on children's rights. And they note that states should create employment conditions within business enterprises, which assist working parents and caregivers in fulfilling their responsibilities to children in their care. They talk about family-friendly workplace policies, parental leave, support, and breastfeeding. So one example here is breastfeeding-friendly childcare. The Carolina Global Breastfeeding Institute, which is here at UNC, has a training program for childcare providers. And an increasing number of states have a designation for childcare providers that undertake to become breastfeeding friendly. So it is not unusual in centers that have not undertaken this kind of training for a parent to be nursing their baby at the childcare provider and be told, you can't do that in front of the 3-year-olds, that's disgusting. Doesn't make any sense, but this is the world we live in. It is also not unusual for childcare providers to be like, ew, we can't have breast milk in our refrigerator, it will contaminate all the other milk. Or for providers to pour out milk or to overfeed babies and then tell the birthing parent who's working really hard to express milk that there isn't enough milk and they need to produce more, they need to supplement. So it's really important for childcare providers to understand how infant feeding works in order to enable families to be successful. Now, paid leave is one of the really important drivers of health and well-being for birthing people and their children, and also for breastfeeding. And as many of y'all probably know, California was the first state to enact a paid leave policy. So go California. It just celebrated its 20th anniversary. And this is the website where folks can look up the specifics of these paid family leave benefits. Now, it's awesome, fantastic, amazing that California has paid family leave. And it's also not clear that everybody actually knows that this exists. So it's fabulous to have a benefit, but if people don't know the benefit exists and don't access it, it isn't particularly helpful to them. And so I read with interest this paper in Health Affairs that looked at low-income women in San Francisco and their awareness of paid parental leave benefits. So this was published in Health Affairs. And the authors looked at before and after the passage of additional paid family leave provisions in San Francisco, and the extent to which individuals with Medicaid versus non-Medicaid understood the benefits, found their employer to be helpful, and then where they got their information. So very few Medicaid recipients got information from their employer, a little bit more got information from the healthcare provider than non-Medicaid, but a substantial proportion of Medicaid recipients receive no help in understanding the benefits. So I think we often are handed FMLA paperwork to fill out, and it's sort of like, oh no, we have to fill out this paperwork, and who do I give this to, and how is this going to happen? However, what we really should be doing is at that 28-week visit where we're talking about postpartum stuff. So tell me, what are your plans? Are you planning to work in the paid workforce after birth? Have you explored paid family leave? What do you know about paid family leave? And I'm not asking us in our 15 minutes as obstetricians to be in charge of the entire paid family leave conversation, but we ought to have someone in our office who understands how that works and be able to share with patients really clear guidance about how to access the benefits that exist. I think one of the sad realities of the way that assistance is provided in the United States is those who need it most have the most difficult getting it. And the forms are often opaque and the paperwork is complicated. And it almost makes you feel like they don't really want the people who need the things to get them. As a side note, a couple of weeks ago, I was trying to help a patient who did not have a cell phone access the Lifeline cell phone benefit. And we discovered that to get a Lifeline cell phone, this is a Federal Communications, an FCC administered program, you need to provide an email address. Guess what people who don't have cell phones typically don't have? Email addresses. So we need to recognize that there are these barriers that make it more difficult for people to get access to benefits that exist. And in addition to advocating for the benefits to exist, we need to make sure that people are able to access them. And then we can talk about breastfeeding in public. So the good news is that all 50 states, the District of Columbia, Puerto Rico, and the Virgin Islands have laws that specifically allow women to breastfeed in any public or private location. And yet there's a profound double standard. So this is a cartoon that was published in the Los Angeles Times, which unfortunately reflects the fact that if you Google Victoria's Secret breastfeeding woman thrown out, multiple instances come out of where nursing mothers and parents have been in a Victoria's Secret buying products and then told that they can't nurse their baby in the Victoria's Secret because, you wouldn't want to expose your breasts in a store that makes its money exposing breasts. And I think that it's important to appreciate that this double standard and the sexualization of breast is a substantial barrier to people being able to actualize their infant feeding goals. If the birthing parent or their partner or their family thinks that breasts are dirty, disgusting, can't be seen, they need to go lock themselves in the bedroom and close the door if they're going to nurse their baby, that's going to be a substantial obstacle. And you might think, well, this doesn't happen anymore. This cartoon's a couple of years old. This weekend, I was using the Microsoft Word dictation function to dictate notes for my lactation clinic patients. And I said to Microsoft Word, the patient describes significant breast and nipple pain. Microsoft Word does not transcribe the word nipple because, nipple is porn. So I've written an angry letter to Microsoft. Interestingly, this led me down a rabbit hole. If you dictate the word penis, Microsoft Word has no problem with that. If you just dictate the word clitoris, it does have a problem with that. So I think there's some misogyny buried in here as well. But if you think about it, if software engineers at Microsoft feel like they have to redact the word nipple because it's somehow disgusting, these are the ways that negative thoughts about infant feeding get embodied in our culture. And it does suggest that, ew, nipples. I mean, you put a nipple on, anyway. I wanted to share this with you all because I think it illustrates the ways that the sexualization of the breast as a body part pervades all different aspects of our reality and can impact the lived experience of our patients who want to feed their babies with their bodies. So now I'm going to shift gears and spend the balance of our time together talking about how maternity care providers can enable women and birthing people to achieve their infant feeding goals. And this really begins with evidence-based care that has been shown to enable more people to breastfeed successfully. It also requires us to really center the patient. Chanel Portia Albert, who is a brilliant birth justice advocate in Brooklyn, spoke at Decolonize Birth 2019 and said that every birthing person should be able to say, I am seen, I am heard, I am loved. And I want to think for a minute about how we can show up and ensure that each of our patients is truly seen, heard, and loved. One of the ways we can do that is through shared decision-making. And I love this concept that shared decision-making brings at least two experts to the table, the patient and the provider. Providers are experts in the clinical evidence, and the patient and their family are experts in their experiences and values. So once upon a time, we had a paternalistic model where the provider dispensed information and recommendations, and the patient did as they were told, or didn't do as they were told, but the provider didn't talk to them about it. Then there was a recognition that we shouldn't recommend things, we should just provide information. But providing the patient with a bunch of information without context, without knowledge of their values and preferences is not particularly helpful. So a shared decision-making approach elicits the values and preferences of the birthing person and then shares information and recommendations to help the patient determine what aligns with their values and preferences. I was sharing this back in the days before Twitter was X. I used to tweet out this slide, and Efe Asiado, who's at UCSF, many of you may know her, said, well, actually, I think you need to add something to this picture. It's not just one provider, and it's not just the birthing person. It's the birthing person and their family. And so we need to be thoughtful and respectful of the whole group, because if grandma doesn't want the patient to do something, and we elicit the birthing person's values and preferences without including grandma is certainly going to assert their opinion when we leave the room. And so it's a good idea to engage everyone in that conversation. Importantly, shared decision-making does not mean that the patient and their family share my opinion at the end of the conversation. And I think that sometimes when we're making really difficult decisions, I think this is what should happen next, and the patient doesn't think that. And I hear myself starting to make scarier and scarier assertions to try to get the patient to align with what I want them to do, instead of recognizing that they are the expert. They have lived in their body their whole life, and I need to honor their preferences. That's a phrase that I use a lot in counseling, partly to name the patient's expertise and lived experience, and also to remind myself that the patient has that expertise and lived experience. So I invite you to try on, when counseling a patient later today, tomorrow, this is what I would recommend. And you have lived in your body your whole life. And so it's important for you to think about what makes sense to you. I will also add that I use this phrase so much that once in a conversation with my 15-year-old son, I think he was grumpy, and I said, maybe you're hungry. And he said, I'm not hungry. And I said, you've lived in your body your whole life. And then I looked at him and said, but you lived in mine first, so you need to have something to eat right now. So except for your own children, everyone else has lived in their body their whole life and gets to decide what to do next. So in that spirit, if we think about supporting breastfeeding goals and chestfeeding goals, we know that the 10 steps to breastfeeding are evidence-based practices that enable individuals to meet their infant feeding goals. So these are the 10 steps, and I know y'all are about to go through a baby-friendly visit, so I will not read all of these to you, but I'm going to highlight a couple of these as we think about the impact that these practices have on infant feeding outcomes. And I want to underscore that this is not some people who sat down and said, these sound like interesting ideas, we'll go for it. There's actually compelling evidence in randomized controlled trials. And the first major study was conducted in Belarus in the late 1990s. And hospitals were randomized to the Baby Friendly Hospital Initiative, or usual care. And individuals intending to breastfeed were followed prospectively for a year. And what they found was that by birthing in a facility that was baby friendly, there was a higher rate of breastfeeding out to 360 days postpartum. So one might say, well, it doesn't really matter. They're only here for 2 days. Like, this is not necessary. People are going to do what they're going to do. But in individuals who wanted to breastfeed, so they initiated breastfeeding, there is a difference out to 360 days postpartum. We also know that the experience of these baby-friendly practices is directly correlated with women meeting their infant feeding goals. These are data from the Infant Feeding Practices Study. And among individuals who intended to breastfeed for at least 2 months, this is the proportion who stopped before 6 weeks as a function of how many practices they experienced. So if they experienced 0 of the 6 practices that were measured in this survey, 30% did not meet their infant feeding goals. If they experienced all 6, only 3% had not met their infant feeding goals. So if we could have a show of hands, and we can't because of Zoom, I'm imagining that everyone knows someone who wanted to breastfeed and it did not go well, or did not go as well as they hoped it would. And I want you to consider that if a hospital doesn't have any baby-friendly practices in place, then 1 out of 3 people will find their experience does not go as they desired. And if we have 6 of them in place, then 1 out of 30 will not be able to meet their goals. So this is a really profoundly impactful intervention. It is also really important for health equity. So the CHAMPS team, which is based at Boston Medical Center, implemented a hospital and community-based initiative in Mississippi, Louisiana, Tennessee, and Texas from 2014 to 2017. And they specifically worked on skin to skin, which we'll talk about, after vaginal birth and C-section, and rooming in. And you can see here, there's a substantial increase in skin to skin after vaginal birth, after C-section, and rooming in during the study period, and they break out by race and ethnicity. The lines are pretty similar. What's profoundly important, however, is when they look at breastfeeding exclusivity during the hospital stay, the practices of skin to skin during C-section and rooming in were significantly impactful for African-American families, who typically have lower rates of breastfeeding initiation and continuation. So this increased breastfeeding rates for everybody, but it was most impactful for Black individuals, suggesting that this is a powerful mechanism for reducing disparities in infant feeding outcomes. So when we think about implementing the Baby Friendly Hospital Initiative, we're thinking about a health equity initiative that helps to enable folks to have consistent outcomes. So one of the baby-friendly steps is to discuss the importance and management of breastfeeding with pregnant women and their families. Now, when I first started doing maternity care, I asked, as many people do, breast or bottle? It seems like a straightforward question. You get a yes, no answer. You move on. But the problem with breast or bottle is that if the patient says bottle, then either I have to say, okay, or then I have to say, well, I don't want you to do that. I want you to do breast, that's not listing values and preferences, right? That's eliciting the decision rather than sharing it. And what I found to be much more effective, and what I recommend you try on for size if you haven't already, is to ask, what have you heard about infant feeding? And there's a wonderful story that may be apocryphal, but I love it, so I'm going to tell it anyway. About an instance when a provider said, what have you heard about infant feeding? And the pregnant person said, well, I don't want to do that. I don't want to breastfeed. It's too painful. And the provider said, well, say more. What exactly are you concerned about? And the patient said, well, I don't know what they used to make holes in your nipples with, but I'm not doing that. And the provider took a breath and said, holes in your nipples? And the patient said, well, I've seen baby bottles. They have holes in them. I don't have holes in my nipples. That must be why it hurts so much, because they pierce your nipples. So the provider was able to explain that actually the holes in your nipples are already there, right? That there are multiple nipple pores out of which milk will spray at delivery. And the patient, oh, well, if you're not going to have to pierce my nipples, then I'll do it. That sounds great. So no amount of carrying on about the health impact of infant feeding, blah, 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 would have convinced this patient to do this if they really thought they were going to have a piercing procedure to start breastfeeding. And by asking those open-ended questions and following up, the provider was able to help the patient make an informed decision. So there are some concrete tools for having that conversation. The Ready, Set, Baby resource developed by the Carolina Global Breastfeeding Institute, which has been translated into multiple languages, includes a booklet with information about what have you heard about infant feeding. They also have a virtual prenatal education class that's offered multiple times a week. I think is at 3 p.m. Eastern time. Folks from California are more than welcome to log in. It's offered in Spanish and in English. And they also have a flip chart, which y'all could incorporate into your clinics if you haven't already. On one side, it says, what have you heard about infant feeding? And then on the other side, for the person who's doing the teaching, they have specific prompts and pointers to cover. So this is a tool that can be brought into your clinics and shared with patients to go over what to expect around infant feeding. Those open-ended questions are particularly important when we think about inclusive feeding support. So not all individuals who lactate identify as women, and not all couples are comprised of heterosexual married people. And so it's really important to ask couples when they come in for prenatal care, what have you heard about infant feeding? For example, if you have a couple with 2 women, it's possible for the non-birthing parent to induce lactation. It is also possible for transgender individuals to induce lactation. And I think that there have been a handful of qualitative studies that have really tried to look at this experience. And Trevor McDonald, who is a trans man who has chest fed for many years and has become a really fabulous advocate in this area, talks about the fact that people may make an assumption that a trans man would not want to lactate and won't bring it up because they would think that it would be that would cause gender dysphoria. And there are certainly individuals for whom it does, but there are also individuals who find that they really want to lactate and that they want that support. So by asking our patients with different gender identities, what have you heard about infant feeding? We can explore all those different possibilities. So a wonderful resource for this is the ABM Clinical Protocol on Lactation Care for LGBTQ patients, and it walks through a number of different topics. It talks about creating a respectful healthcare environment, the effects on transition-related care, fertility options, inducing lactation and co-lactation, birth plans, additional considerations in the hospital and NICU, and then they have a model co-lactation feeding plan. Because even with the most thoughtful and intentional prenatal care, if the patient and their partner appear at the hospital and people are like, what is this? What is this co-lactation? That is not helpful and supportive. And so the co-lactation feeding plan is an opportunity for folks to lay out how they intend to feed their infant after birth. And I just want to share a story that earlier this month I was on, or I guess last month, I was on the antepartum service and I was caring for two women who were married, and the pregnant person had undergone a mastectomy for a BRCA2 mutation. And as they got close to birth, they were delivering at 34 weeks because of complications. They asked about access to donor milk, and it turned out that the partner had breastfed an older child for 3 years. And I said, well, it is possible to relactate. And she said, oh, I can relactate. And it ended up being something that she wanted to initiate. And so she was able to express some colostrum. I had a consult with them last week. And she's very excited about providing some human milk to their son and doing that with some hand expression and with inducing lactation with a pump. However, it hadn't come up previously. And I can imagine that one's mindset might be, well, the birthing patient had a mastectomy. She's going to feel sad if we ask her about breastfeeding, so let's not do it. We'd asked, what have you heard about infant feeding? Can actually induce lactation more effectively if you start ahead of time rather than waiting until after delivery. And so in some ways that was a missed opportunity. They also have been incredibly grateful for the care they've gotten and are really happy with their plan going forward. So I encourage you to include early in your counseling, what have you heard about infant feeding, regardless of the context of the family, so that we can provide tailored support. Another critical piece of baby-friendly care is facilitating immediate and uninterrupted skin-to-skin contact and supporting them to initiate breast and chest feeding as soon as possible after birth. So that skin-to-skin support enables normal physiology. And that contact in the first hour of life can be a critical period for nursing success. So these are data from a Cochrane meta-analysis looking at the impact in randomized controlled trials of skin-to-skin care uninterrupted in the first hour on infant feeding outcomes. And what they find is a markedly higher rate of a successful first feed, of exclusive breastfeeding from discharge to 1 month, of breastfeeding at 1 to 4 months, and at 12 months. The bottom line is that birthing parents who held their infant skin-to-skin breastfed 42 days longer than those who did not. So when we think about a powerful intervention, 42 days, it's 6 weeks of additional feeding, simply by supporting that baby to be skin-to-skin at birth. So I know we want to do eyes and thighs. I know we want to take the baby over the warmer, but unless there is a compelling medical reason to remove the child from the parent's chest, that is the best place for baby to be in that first hour. There's also data that blood sugars are higher, reducing risk of hypoglycemia, that baby temperature is maintained better with skin to skin. And when they've done injections like heel pricks, babies cry less when they're skin to skin during that process. So there are myriad ways that we are making things better for that infant and that parent by keeping the child skin to skin. It's also important to support families to recognize feeding cues and to room in for 24 hours a day. So I mentioned that my first son was born the night before the match. This is me as a fourth-year medical student. This is Noah. And in the video clip taken at the same time, I say, gosh, you just breastfed for 15 minutes on the left breast. So in 3 hours, you can breastfeed on the right breast. And Noah is giving a very, very clear feeding cue, which is feed me. Babies cue very clearly, and no one in the room mentioned to me that perhaps the baby's hand in his mouth indicated that although he'd fed for 15 minutes on one breast, he was not done. By the time my third kid came along, I was wise enough to take a picture to use in breastfeeding talk. So this is Max cueing. Babies have a fuel gauge. This is empty. This is full. This means I might want dessert. And it's important that we share this with parents, because if they wait until the baby is crying loudly, then the baby is not in a great frame of mind to figure out how to attach to the birthing parent. And so these early feeding cues of rooting, mouthing, pulling your arms up like this, sucking are all signs that baby wants to feed. And if we can support families to put that baby to breast or to chest in a timely fashion, they're much more likely to be successful. Now, there are fantastic resources that I've been sharing for years right at Stanford from Newborn Nursery on getting started with breastfeeding. And I actually regularly pull out this page on people's phones and point to some of these videos as being really, really helpful. If you aren't already aware of this, please check it out and share it. There's a wonderful video about hands-on milk expression for individuals whose babies are in the neonatal intensive care unit. And they're just really helpful tools to share with your patients. I also want to touch for a moment on shared decision-making around contraception. I mentioned earlier in the part about reproductive justice that reproduction has been stratified in the United States for many years. And many people of color and those with marginalized identities have had contraception pushed on them. There's an impression that they have too many babies, and if they would just stop having babies, then they wouldn't be poor and they wouldn't face discrimination, which is completely insane. But that legacy, when I say to a patient, what do you want to use for birth control? As a 50-year-old white lady, I am potentially telegraphing that I think they should not have more babies. And so what I encourage you to try on, and this is another thing to do in your next consultation, is might you want to have another baby? If so, when? And that opens up a very different conversation than the what do you want to use for birth control? If the patient says, oh, never, absolutely not, then the conversation is, well, what are your thoughts about how to accomplish that? And if the patient says withdrawal, we can have a conversation about how that's not the most aligned idea with absolutely not, never. Maybe there's a more effective method. On the other hand, if the patient says we've been using withdrawal for 20 years, we've had 2 kids, the only times we wanted to, we like withdrawal and it works for us. Again, shared decision-making does not mean the patient shares my opinion of what to do at the end of the conversation. On the other hand, if the patient says as soon as possible, that opens up a conversation about birth spacing and the fact that at least 6 months, but ideally 12 to 18 months before conceiving again is what we recommend so that the birthing person's body can heal. This is particularly important in the context of breastfeeding because of the role of progesterone in the onset of milk production. So this is just a reminder that people really do have complicated histories around the experience, or populations have had complicated histories around the experience of contraceptive counseling. No Mas Bebés is about forced sterilization in California in the 1970s. And this is a quote from a focus group participant: birth control in general makes me really wary because it was meant to keep people like me from procreating and having more of us, right? I don't really trust doctors because I don't know what subconscious things are going on when certain methods are being recommended to me. And then these are data from UNC looking at immediate postpartum Nexplanon placement. And what you'll see is that younger individuals with Medicaid insurance, individuals who identify as Latino or non-Latino Black, or who are Spanish speaking have much higher rates of Nexplanon placement than other groups. You can see among privately insured, it's only 0.5%. Now, it could be that people with Medicaid love Nexplanon and people with private insurance don't like it. And this is completely driven by patient preference. But given the history of how counseling has happened in the United States, I have a feeling that's not the only thing that's going on here. And if we think Nexplanon is a good method, we should be offering it to everybody. And if we think Nexplanon is only a good method for certain people, we need to inspect our opinions. And that is important because falling levels of progesterone postpartum coincide with upregulation of prolactin receptors and the onset of lactose synthesis and milk production. So here is progesterone going down, and here is lactose and milk going up. And you can see that those are timed very synchronously. We published a case report of a patient who, a parent and baby dyad who received care at UNC, here who received an Nexplanon placement at about 40 days of life. And this is the infant's growth curve, which rapidly fell off the curve. This is a case report. A case report has a p-value of 1, right? 1 instance. However, given the role that progesterone plays in onset of lactogenesis, we wrote, and this paper was co-authored with family planning faculty, giving uncertainty regarding the true effects of implants on lactation, it seems prudent for healthcare providers to counsel each woman about a possible effect on milk supply so she can monitor infant for signs of impaired milk transfer. I do want to flag that there are randomized controlled trials that do not show at a population level differences in breastfeeding outcomes with early next-to-none placement. However, in this case, this was healthy postpartum women with healthy term babies with adequate weight for gestational age who were breastfeeding well, and we're in Brazil, which is a country with much higher overall rates of breastfeeding than we have in the United States. So whether in the context of for social support, of early return to work, of a baby in the NICU, there would not be an effect is not known at this time. So how do we think about shared decision-making? We can ask about values and preferences. These are some questions we might consider. We can share information and recommendations. And if the patient says the most important thing to me is breastfeeding my baby, and I am confident that I will get back for a next-to-none placement, or that I can use a barrier method, or that I'm not going to see my partner because they're being deployed or whatever, then we can place the next-to-none at a later date. So it is not the only opportunity we ever have to provide contraception to the patient. And I think it's incumbent upon us ethically to provide full information. So in the last couple of minutes, I want to leave some time for questions. I also just wanted to share the importance of providing anticipatory guidance about everything postpartum in order to support our patients in their healing and recovery. So Elizabeth Howell did this great study in the 2000s where individuals were randomized to 15 minutes of anticipatory guidance about common symptoms postpartum compared with usual care. And what they found was that there were lower depression symptoms in the group that got this guidance out to 6 months postpartum. And there were higher breastfeeding rates. And I think this speaks to the fact that if one is at a loss for how to manage all the things that go on postpartum, one of the many things that can come undone is infant feeding. And if people know what to expect and they have some coping strategies, then all of these things are going to be easier. So in that spirit, at UNC, we've developed a website called newmomhealth.com and a Spanish sister site, saludmadre.com, which is an expert-written postpartum self-care information hub. And this was designed with extensive input from individuals' lived experience who told us about what they wanted and what they needed to know. So we have resources on a bunch of different topics. And part of what was really fascinating and fun about this is we should have shared a first draft of this. And I think the emotions and hormones button said depression, anxiety. And we'd gone to meet with individuals who are part of a Black women's breastfeeding support group. And they said, I'm not going to click on depression, anxiety. We said, what about emotions and hormones? So like, yeah, I'll click on that. I think we also had perineum instead of bottom and pelvic. No one knows what perineum is except obstetricians. So we changed that. But there were a bunch of efforts to change this. We also were very intentional about choosing a variety of images. So this is not all well-to-do white ladies with giant rings on their fingers in front of their 4,500 square foot house. We really tried to provide a diversity of images of parents and birthing people. We also provide information about postpartum plan, about relationships with partners, about return to work and school to really support people in building their village. These are two specific resources I wanted to call out around birthing parent health information. And these, again, were developed with lots of feedback. They're in English and Spanish. They fit on one page. They include sort of reasons to call 911, reasons to call your health provider, and then sort of really short, succinct bullet points about things people might want to pay attention to. If I have piqued your interest in breastfeeding and breastfeeding medicine, I encourage you to check out the Academy of Breastfeeding Medicine. We've just released brief 10-minute, whatever your physician needs to know about breastfeeding videos that give you an intro to key topics in breastfeeding medicine. I also encourage you to consider joining ABM. That's how Dr. Crow and I know each other, I think. We met through ABM, and it's a wonderful organization that really is dedicated to making sure that healthcare team members know what we need to know to provide excellent support for families around infant feeding. So these were our objectives. We've discussed that enabling lactation can improve lifelong health for birthing parents. We've discussed that every birthing parent has a human right to breastfeed or chest feed their children, and that maternity care providers play a central role in enabling people to achieve their infant feeding goals. I'm going to close with the words of Joya Perry, who's one of my sheroes. What would it look like for mothers to not only survive pregnancy, but to thrive? Thank you.
All right, thank you very much, Dr. Stuebe. We have a couple of questions that I'd like to ask you here today. One is from Dr. Amanda Williams. Hi there, thanks so much for sharing so many tips about counseling patients. When I was at Kaiser Permanente, one of the most impactful interventions we tried was peer matching breastfeeding buddies after hearing that many of our African-American patients didn't identify with our lactation consultants. Can you please comment on impact of group care, centering, and peer support?
Yes. More and more and more. Yeah, I think that that's critically important. And I really do think Mahogany Milk is an organization that's based in Greensboro that is a Black peer-to-peer support for breastfeeding organization. And I was seeing a patient this morning who I hooked up with my friend Jania, who runs Mahogany Milk, because I appreciate how important it is to have that shared experience. I think that it's also important to think about the lactation workforce and why it is that the overwhelming majority of IBCLCs are, frankly, white women. And I think that there's a program at North Carolina A&T, which is the largest HBCU, I think, in the country, that my friend Jania, I lecture in, that is training Black individuals to become lactation consultants so that we can build a pipeline of individuals who look more like the patients we serve. So I think both and I think that having those spaces, community is everything, always, especially in the postpartum period. And when we create spaces for people to come together to share their experiences where they can feel safe and heard, it makes a tremendous difference.
All right, thank you. Another question: beyond government and healthcare system interventions, can you comment on the role of intergenerational support on breastfeeding initiation and continuation? So may have some similar themes.
Yes. So I think that, you know, the 70s were the nadir for breastfeeding in the United States. I was formula fed, and when I first started giving breastfeeding talks, I asked my mom for a picture of her bottle feeding me in the hospital and her bringing me home on her lap in the front seat of the family car. And I had this like car seats and bottle feeding where, we've changed. And she wouldn't give me the picture. She brought me the car seat picture, but not the bottle feeding picture. And so I think there's a lot of both sense that I think there's grandparents who feel guilty or feel awkward or feel like they didn't do the right thing, and they channel that. That's why all of us have been babies and all of us have been parents is really important. And I think it's also important to include intergenerational folks in the conversation. So as the person's families in the room say, what have all of you heard about infant feeding? And direct that to the other individuals, and then acknowledge that and talk about that. I think that there's also space for thinking about inviting, certainly one support person needs to be included, and there's a tendency, I think, to walk into the room and put our backs to the person who's on the couch, who's the support person, and talk to the birthing person as though the other one isn't there. And I think we need to include the whole social network, because this is not an individual event, this is a team sport.
Great. And then another question: social media has a huge influence on our patients. With the goal of avoiding misinformation, which resources do you like to point people to on social media or otherwise? You mentioned the
Ready. So I think Ready Set Baby is a great resource. Nurse Nikki is this fantastic nurse practitioner. She's done some videos for the Fourth Trimester Project that are really fabulous. And she's super approachable and lovely, and she has an active Instagram presence. I think that I'm trying to think, there is a group in California that does great work that I can't think of right now, but I think it's also important to go and check out some social media and listen to what they have to say and kind of gut check it, or ask your patients who they're watching and then watch it and see if it's good or not, because probably the white lady from North Carolina is not going to have great resources for contemporary birthing people in California. But I think that there's definitely a huge social media presence from the formula companies, and they make it sound like they feed the fire, they fuel the mommy wars to keep people thinking that breastfeeding is some oppression as opposed to formula marketing is some oppression. So I would definitely be aware of the formula company stuff because they're spending a lot of money to sell their product.
Okay, great. It's 8:30 right now. I'm going to put in one more quick question about if a patient comes in from a very paternalistic situation and is sort of forced to do what she doesn't want to do, how do you negotiate that situation?
So I think that is a thing for breastfeeding and for all of the stuff we do, right? I mean, someone can be forced to have a baby they don't want to have. They can be forced to not go to work or to go to work. There are all sorts of places where unhealthy relationships happen. And so I think this fits in the same context as any other coercion of behavior for our patients. And so I would think about reaching out to your partner violence resources because someone's being coerced to do something and being threatened in some way, emotionally or physically, and that's not okay. And again, I think people can be told that's nasty, don't do it. Like, ew, breastfeeding's disgusting. How dare you put your titty in that baby's mouth? And they can also be told, you better not give that child a bottle. Your role is to be subservient and breastfeed, and both of those are wrong. And so I think that we need to understand our individual patient needs. And then in those situations, one of the things I remember learning as a medical student about in partner violence is the patient is the expert. They understand their context. They understand what's going on. And there's a tendency for us to swoop in and be like, I'll fix this. But then A, we are assuming power and control, which is the problem. And B, we don't know what the right thing to do is in that context. We want to connect that person with resources and support them so that they can make the decisions that make sense for them.
Okay, and I promise, thank you. Last question. So, Dr. Kate Shaw, thank you for a wonderful talk. How do you think providers are influenced by the unbundling of contraception from the global, has influenced, like the global prenatal package, has impacted Medicaid and Nexplanon initiation versus private insurance, which has not unbundled it? And
Yeah, I mean, money talks, right? And I think that I clearly believe that access to highly effective contraception is really, really important to the well-being of people with uteruses. And so I'm all for it. And it's a commercial product. And the people who are selling that commercial product want to sell more of that commercial product, whether it is for people who really, really want it or people who will tolerate it or people who are afraid to say no to it, right? And so I think that difference in who gets the placement is certainly a potential driver. And I think we just need to be really aware of commercial determinants of health across the board. When I was a medical student, we got all sorts of free junk from pharmaceutical companies, and we thought that was normal. And I think that's become much less common than it was. But we live in a late stage capitalist society where making money is the highest good, and that affects the care that we deliver. And we need to come together and fight to change that, so that we don't continue to have that be the case. So.
all right. Well, thank you. And thanks to all of you who stayed on a couple minutes late, and have a great day. Thank you so much.
Thanks so much for having me.